Hi, everybody. I'm Dr. Carolyn Alexander. I'm sending peace and good energy to everybody who's facing the challenges of the fire. I grew up near the Palisades, so I feel for all my friends and my relatives and cousins who have lost their homes and businesses. And my heart is with everybody in Los Angeles, all the fires and all the brave firefighters. Many of my patients are firefighters, so I'm very grateful to them. I know today's Dr. Surrey's birthday. Happy birthday, Dr. Surrey. I'm looking forward to the webinar. And feel free to ask us any questions through the chat. We're happy to answer any questions. And I think it's an important topic of how to pick a fertility clinic and feel a connection with your doctor and the team and the nurses. And our embryology lab has been here since 1999, and we work very closely together. We're constantly trying to stay at the cutting edge and work really hard to have the best success for all of our patients who are very precious and special to us. So next slide. I was born and raised in LA. My research has been on polycystic ovary syndrome. I've done a lot of research on recurrent pregnancy loss, trying to understand why that occurs. We've really improved the statistics of egg freezing and the survival of the egg thaw and strategies to improve fertilization of those frozen eggs. I think it's important to, like I mentioned, to feel comfortable with the lab and your physician and to get your questions answered. I went to UCLA, which go Bruins, but I have a lot of patients that are Trojans, so we love the Trojans too. I trained in Baltimore at Johns Hopkins, which was a wonderful experience. I actually really liked living in Maryland for 7.5 years. So that was fun. And then I came back to Los Angeles and I've been using our embryology lab since then. And it's been a great honor and privilege. Next slide. I think Dr. Surrey's almost on. He's our co-founder and medical director of SCRC. He's a leader in the field. His team was one of the first to do PGTA, which on the West Coast, which was very exciting. And he has worked really diligently and hard to have an amazing pregnancy rate and worked really hard to give individualized, compassionate care. And with his team, who I love so much like family, his nurses and teammates are amazing. And so all of us here work in a group effort to help all the patients. Next slide. So we're going to talk about what to look at for fertility clinic, treatment options, advances in fertility, and success rates of how to approach our team, how to, and to get any questions answered. Next slide. Okay, so it's important to think about all the different diagnostic tests. We have an HSG capability here, which is the fallopian tube test. We'll go over how we do that. We have our team is led by Desta, who helps us get our blood test results back within a few hours. So our diagnostic testing for hormones, we get them back pretty quickly, and it's done in our facility. Here we have the capability to do the semen analysis, and we get the results back within a few days, as well as sperm DNA fragmentation. So a lot of the diagnostic evaluation to understand why a couple's facing infertility, or if you're single and thinking about starting a family and want to get tested to understand your fertility options, we have all the diagnostic testing here. Our team gives quality, compassionate, individualized care and really puts a lot of heart and effort into each person and tries to do the best we can to get the best quality eggs, the best quality sperm. So we prepare you with a lot of vitamins, nutrition, and talk about acupuncture and lifestyle modifications. I know right now with the air quality and the fires, we're getting a lot of questions about the impact of those things. And so we're ready and available to talk about it. We have our state-of-the-art embryology lab, which is part of our unit right here on the 5th floor. And they work really hard. They have the best air quality system to protect the eggs and embryos and sperm from any outside particulate matter. And that has helped us improve our success over time. And our in-house surgery center, which is led by Ashley, who's amazing. She's our nurse coordinator there and nurse director, and she's like really dedicated. She understands fertility. She knows what patients are going through. So there's this connection with the facing the good things, the hard things, everything together. So next slide. So our team has a proven track record. We've been here a long time. We have an office in Beverly Hills. That's our main hub where we have our embryology lab. And we have an office in Pasadena, as well as a full state-of-the-art Santa Barbara facility with an embryology lab there, which is directed by Jessica Crowfoot, who's amazing. She and I have been friends for I think 15 or 20 years. But anyway, so it's a fantastic place. And it's a privilege to work with our partners, Dr. Surrey, Dr. Danzer, and Dr. Maxwell, who are all very dedicated and ready, willing to help any patient. Next slide. So in terms of the treatment options, I think it's important to recognize we try to understand why is nature, if we're trying for 6 months and why we're struggling to get pregnant. When you're under age 35, sometimes people are told try for about a year, but make sure to have regular periods. If you're on any medications, talk to your doctors, whether it's either partner, because sometimes medications can impact sperm quality or egg quality as well. It's important to think about our family history in detail. So if we have a strong family history of a specific type of cancer, there are some preliminary tests that we can do. We have a genetic counselor with us on our team, Caroline. She's fantastic. She's very equipped to help us understand if there's any deeper dive into genetics that we should do to help protect your next generation. We do a comprehensive and appropriate treatment pathway. We look at polycystic ovary syndrome, try to work closely with nutritionists, as well as encourage mindfulness, meditation. We think carefully about endometriosis and the pros and cons of further evaluation, such as laparoscopy or any further testing to understand the extent of endometriosis. And each of us works hard to understand how to get a healthy pregnancy for you guys. Next slide. In terms of the medical history, it's important to come prepared to the visit if you can. So if you had at your recent pap smear appointment, they did a thyroid test or any of the fertility hormone levels, such as a day 3 of your menstrual cycle, FSH, estradiol, LH, or you've had a pelvic ultrasound report, or if you did have an MRI for any specific reason and you have the report, it'd be helpful to bring it to your visit. Some visits are on video or in person, or on the phone, but you could send them to us and then we could prepare for the consult. It's important to think about a mammogram, especially if we're at age 40. And it's important to think about a baseline mammogram or talk to your OB/GYN about that as well. And also to get your annual physical exam. I just had a patient where I encouraged the male partner, please think about getting an annual physical exam, and we caught that he had hyperthyroidism. So it's important. Sometimes we're focused a lot on the egg quality and the age of the woman and all these details, but it's really important to take a step to understand the full picture and really recognize that both the egg and sperm plays a big role in embryo development. We do a physical exam. We do a pelvic ultrasound to look at the contour of the uterus, that there isn't any Müllerian anomalies or abnormal shape to the uterus. Sometimes we can detect a unicornuate uterus, which is an abnormal shape or development, or a septum in the uterus. That's important to recognize. We look at both ovaries and we want to count the follicle count to understand the ovarian reserve or baseline level of how the supply of eggs are. That can fluctuate, so don't get alarmed. If you have a borderline number on 1 month, that doesn't mean it's perpetually going to be that way. It can improve. And we look at all the diagnostic testing. So we try to think about the fallopian tubes. Are they open? Are there any swellings there, such as a hydrosalpinges or isthmica nodosum, to look at the little outpouching on the fallopian tubes? We try to understand the contour of the uterus too, as well as the ovarian reserve tests, a semen analysis, and depending on lifestyles, there can be further testing with urology to better understand how to improve sperm quality. Next slide. So the female testing or the ovarian reserve tests are, oh, Dr. Surrey joined in. Here he is.
Hi.
Happy birthday.
Thank you.
Many more. Yeah. So
I stopped having those at 12, I think.
yeah. So I think we started a little bit into the diagnostic testing, and right now we're just going through the first part, and then we'll transition to your part as well.
No, I've heard it was terrific. Good job.
Okay. So the AMH is just a blood test. It's released from the granulosa cells around the egg. And AMH is a reflection of supply. It can be falsely suppressed from long-term birth control pills, or a low vitamin D level has potentially some impact on it. So it may need to be repeated if it's not in the normal range. And when you're age 26 to 29, normal's 1.96 to 5.88. 30 to 35, normal's 1.4 to 4.2. 36 to 39, normal's 0.8 to 2.8. And at 40 to 44, it does start to trend downward. So normal's 0.42 to 1.4. But at any age, we're always hoping for it to be above 1. And at age 44 and older, it starts to be normal to be at 0.14 to 0.42. And recognizing that it's not a predictor of who's going to get pregnant. It's just a predictor to guide us on which protocol to try for if you're going to do a fertility treatment option or super ovulation or IVF or egg freezing. It helps guide our decision tree. And so it's just a blood test, but it's important to use it as a tool in conjunction with your age, your FSH, estradiol, and the ultrasound to give a full picture of your ovarian reserve. Next slide. The hysterosalpingogram, I've had it done. It's a bit uncomfortable, but it's a test done day 6 to 10 of your cycle. It's very important to think about taking Motrin or Advil beforehand because it can cause a bit of a bad cramp, but it's a relatively brief test. It assesses the uterine contour as well as the fallopian tubes to look at the patency or the ability of the fallopian tube to be open to catch the egg in the ampulla area, and fertilization occurs in the fallopian tube, and it has to be open. Some people had an ectopic pregnancy and have one tube. That tube can still catch the egg from either side, which is always very fascinating. But the other thing is untreated STDs or sometimes hidden endometriosis can cause swelling of the fallopian tube. So it's important to take a step to understand the fallopian tubes when you're trying to get pregnant. if it's taking a little longer to conceive than average. Next slide. The saline sonogram, or HSS, is a thin catheter that puts saline inside, and we're looking for something that's, you can see here on the right, but this is a uterine polyp that can be a barrier for the embryo to attach. And so a saline sonogram is slightly uncomfortable. It's a little less uncomfortable than the HSG, but it's a test done day 6 to 10 of your menstrual cycle or any day on the birth control pills. And it helps us understand the contour. We can also detect a uterine septum or arcuate uterus or fibroids. And we determine if the fibroid has a submucosal component, which is important to and may impact the heavy flow of a period or cause, sometimes some patients can have anemia or cramps with their period, and fibroids can grow in pregnancy. So it's important to check the size prior to pregnancy to get a sense on that, to monitor it over time with your OBGYN. Next slide. The male testing is very important, as we alluded to earlier. Sometimes we're focused on the woman and the eggs and the age, but it's important to look at the volume. We want it over 2 milliliters, the concentration over 20 million per milliliter, the motility over 50%, morphology over 14%. And studies indicate that 25% of infertility is primarily male factor, whereas 40 to 60% is affected by sperm. And people say, I really want good eggs, I want good sperm. Well, it's important to eat lots of fruits and vegetables, avoid fried food, make sure to keep an ideal body mass if possible, as well as taking the vitamins, trying to have a healthy sleep pattern. I know with the fires, everybody's asking us what they can do. It's good to get those air filters, especially in your bedroom, since you might be there a little longer than other places during the day. If you're outside for a duration of time, it could be important to wear a KN95 or an N95, especially if you might be pregnant. It's important to think about that if you're in areas of Los Angeles that might have poor air quality right now. Next slide. So what are options? We talk about egg freezing. We talk about sperm freezing, especially as some patients are getting older. And so it could be good to prevent epigenetic changes when men turn over 50. Some men are thinking to freeze sperm, especially also if they're going to be facing any chemotherapy or rheumatoid arthritis medications that may impact sperm quality. Sometimes they'll freeze some sperm. Embryo freezing is done for future fertility, especially if we're older and you want to have a bigger family. It could be good to batch or bank some embryos for the future. You may need them or you may not. IUI is called intrauterine insemination. It gives us an option to place the sperm into the uterus at the time of ovulation. We can use donor sperm or your partner's sperm or something called a directed donor sperm as well. IVF is in vitro fertilization, which is an important step for egg freezing or embryo freezing. And surrogacy is an option for some patients who have medical conditions where they're not allowed to carry a pregnancy, or they had a severe complication with baby number 1 and they really it's not safe for them to carry again. We use a surrogate, or specific reasons you can talk to your doctor about. In some situations, we're facing younger women where their body may be in what's called premature ovarian insufficiency, where it's a tough discussion, but sometimes we have to think about egg donation, which is eggs from someone aged 21 to 29. And we think about the genetics as well as height, weight, race, ethnicity, all the different parameters, and also donor sperm. It's important to check genetic carrier screening in each of these situations to check for autosomal recessive disorders, that we don't want either the egg or the sperm to carry the same gene that could impact a pregnancy. Next slide. I think as we talked about earlier, here at SCRC, we work really hard to give individualized compassionate care. We're very much advocating education. Patients bring articles to us to go over, that we're open to questions. We're very ready to hear you out, explain things. So we explain why we're giving a certain medication. A lot of patients appreciate that when we're taking the time to go through each reason for each step along the way. And I think next slide. And I'll pass it on to Dr. Surrey to go over the next steps. Thank you, everybody. I wish you a safe and blessed day.
Thank you, Carolyn. So some of the things that you were mentioning are really important to know about when you come to choosing where you're going to go for your care. You mentioned that care here is individualized, which is really critical. And that you also mentioned the fact that there are staff and facilities here which allow for individual, efficient, quick testing and treatment. Because when somebody comes here, they don't want to spend months and months being tested and being treated. They'd like to be efficient about the way in which their treatment, their care, and their diagnostic process goes on. And that's why the fact that you also mentioned that there are imaging facilities here to include ultrasound and x-rays so that you can do everything in one place. And that includes your treatment. Next slide, please. I think it's great to notice what Dr. Alexander was mentioning about the benefits of nutrition for your fertility. So don't get those Carl's Jr. ads too well fixed out in your head. Next slide, please. Alternative things such as acupuncture, we don't require, but we know that there are many people who enjoy this type of treatment, and so we provide it in case you do want this. And some people do believe it's effective. Next slide, please. Supplements we're very attuned to and in favor of, particularly antioxidants, such as some of the vitamins, vitamin D, vitamin C, CoQ10, prenatal vitamins. We know that these are particularly helpful for egg production, but they're also helpful for sperm production. Next, please. So we want to try to avoid certain toxins that we know are harmful, such as tobacco, cannabis, and excessive alcohol consumption. Next. So we're going to talk a little bit about treatments. So one of the key treatments today involves the ability that we have to access laboratory facilities. Because these kinds of facilities allow us to take somebody for whom we have no explanation for their fertility problems, but it allows us to look at the key part of fertility, which has to do with fertilization, where the egg and the sperm get together, and embryo development, what happens after they get together in regard to their cell division, as well as their genetics. Next, please. So one of the things that we have here, in addition to diagnostic testing, are therapeutic interventions, specifically things like in vitro fertilization that allow us to achieve excellent diagnostic issues for patients, but moreover also therapeutic success. And we have a very, very high pregnancy rate, particularly for older patients. And the reason why we do is because we are able to look at what we call time-lapse analysis of your embryos, which can actually improve upon their quality and allow us to choose which embryos are going to be the best for you and your fertility, along with the ability that we have to do thorough chromosomal and single gene genetic testing of each embryo that looks normal. Next slide, please. So lots of different options that we have. And, when we do your evaluation, we also will look at more natural options in addition to technical options. But, as we talked about, everybody is very different, and there's not one size fits all. Not everybody is benefited by things like acupuncture or intrauterine insemination. And just to be clear, IUI or intrauterine insemination, which many people request, is a version of natural fertility because it amounts to placing sperm that has been washed and treated into the uterus, but it's dependent upon that sperm meeting an egg, fertilizing it, and creating a normal embryo. Next slide, please. So the idea of an intrauterine insemination is great when it works, but should not be pursued for too long. And we usually have a rule whereby we don't do this in a normal patient for more than 3 to 4 cycles. And that's because if it's going to be effective, it's effective in a relatively short period of time. And its absolutely indications have to do with closure of the cervix or issues with the sperm. Next slide. So when we do egg retrievals for things like in vitro fertilization, we do so with monitoring. Your ovaries are stimulated with natural releasing factors that cause you to produce your own hormones in your own follicles. So they're not foreign substances. They take anywhere from 8 to 14 days of stimulation, during which time we need you available for monitoring, which we do with hormone evaluations and imaging with ultrasound. And then the day of the retrieval, it's done without a surgery, but by ultrasound aspiration. And you have an option of receiving sedation, which would be similar to intravenous sedation. So it's not a general anesthetic, but you're not uncomfortable during the aspiration. Next slide, please. So the retrieval kind of looks like this. You are stimulated to make multiple follicles because we know that many eggs that, as human beings, that we create are not going to create a normal pregnancy. So the more that we create, the more opportunities we have to see a normal pregnancy developing before your embryo transfer. And that's the reason why we have such high pregnancy rates. Next slide, please. This is what goes on in the laboratory. This is not 2 embryos, but it's 1 embryo with cells extruded from it called trophectoderm. These cells are being biopsied for their genetic content without interrupting the cells inside the embryo. And this is a very accurate way to tell you about the genetic content of each embryo, which may be different. So next slide, please. This is the way in which sperm is introduced into each egg to make certain that normal fertilization can occur. Next slide, please. This is the key. This is embryo development. This is 3 days, 4 days, and then eventually it will create a blastocyst at 5 to 6 days, which is what can create a normal pregnancy. This is what it looks like. This is what all of us look like to begin with. Hard to imagine, but this is the reality. And embryos that do not look like this, do not develop like that, will not cause a pregnancy. Let's look at that again. Can you see that? 2 cells, 4 cells, 8 cells. And it's really fascinating the way that we can see the beginnings of life here, and we can critique it to be sure that it's going to be normal with this video monitoring system, which is performed underneath an incubation system. So we don't actually take your embryos out of the incubation system to look at them under a microscope. This is analysis that takes place when you're sleeping at home. So it allows us to see each cell division and make sure they're normal before testing your embryos genetically. Next slide, please. So it's important when you choose a clinic to look at their success rates per age, per treatment type, and per embryo transfer. Because when you look at statistics from places like START, they're based upon people who register for the clinic, not based upon embryos or embryo transfers. So that's a much more valid way to assess the efficacy and efficiency of a clinic is by embryo transfer rates. And the embryo transfer rates here, I can tell you, this last year approach 80% for single embryo transfer, which is very, very good. And particularly considering the average age of our patients is almost 38. Next slide, please. So this is what older statistics look like. Our statistics are the blue bars, which are higher than average statistics, particularly for older patients. See, over 38. Next, please. So it's also important to understand the process of cryopreservation because it's critical when it comes to looking at fertility preservation. You know, we talked about the fact that normal pregnancy decreases as we age as human beings, which has to do largely with the genetic content the embryos produced, and it affects females as well as males. So it is impossible to preserve fertility by preserving unfertilized gametes, gametes are eggs and sperm, or fertilized gametes called embryos. When you create an embryo, you know what the unfertilized gamete is going to do. And in our center here, we have a very high thaw survival and fertilization and cleavage rate, as well as implantation rate per egg and embryo. Next. So you need to be comfortable with whatever you're doing. And it's important, as Dr. Alexander mentioned, for you to ask questions, get information, and try to become as comfortable as you can with your process, your diagnosis, and with your therapy. Next. So these are some of our clinicians, and we have all been experienced with this technology for a while, and we're more than happy to be available for you whenever you'd like. So let's see if we have something else, but we want you to ask questions whenever you'd like. Any of us are available to see you when you'd like, and you can ask questions online or in person. So we thank you for your attention today, and we're happy to help you in any way we can. Next. I think we're going to see if anybody has questions today. Do we have any questions today? Let's see. I think we do. So, Dr. Alexander, you here?
Yes, I'm on.
Okay. Do you see the questions?
I think one of them was survival of the egg thaw. It's been 89% on average that eggs that are frozen survive the thaw. Sometimes when we're in our 40s, the survival of the egg thaw may be slightly less. But the flash freeze vitrification has been a really good survival of the egg thaw. Let me see what the other questions are.
There's one about embryo safety in fire areas, and we can assure you that we have a lot of preventional kinds of technology involved with storing your embryos that are done by a vitrification process with backup generators in case there's ever a problem. There's a question, Dr. Alexander. Patients are at age 45 with regular cycles. Are you still considered for egg freezing? Any thoughts about that?
Well, our ethics committee met and we were deciding at 44 egg freezing. We've had survival of the egg thaw in pregnancies. We did just ask our embryology director to do a review of 45-year-old eggs, and they have survived the thaw, but it's very hard to get a genetically normal egg at age 45. It starts to be 1 in 15 of the eggs has a normal genetic complement to make a healthy embryo. So the chances are a bit like much lower. So an embryo would be better to try to freeze than a plain egg, but it's up to the discussion between you and your doctor as well as your ovarian reserve and to go over the pros and cons together.
So there's a question, are all the results of tests discussed, or do you only tell us what we need to know? I think you get whatever information you want and need. And in terms of the results of the test, they're all discussed, and they're all on a portal for you. So you can have and will get copies of all your test results. Dr. Alexander, there's another here. How do you decide what tests to perform for patients already but not sure why tests are being done or run?
That's a good question. I think you know, the impact of vitamin D levels on fertility. We check vitamin D levels. Thyroid can impact vitamin D. Iron deficiency prior to pregnancy can impact risk of preterm labor. And so sometimes patients ask why we're doing specific tests. Interestingly, if we can fix prolactin if it's high, some people conceive relatively easily if we can catch that as a dilemma. So each of the tests can impact the process. But yeah, I think that's a very important and good question. If you have a specific question on the test, we can answer why we're considering it. In cases of diminished ovarian reserve, we start to look into endometriosis a little more cautiously, and that's important. But there are specific reasons for each test.
So there's another question about, I know costs could be expensive. What are steps taken to ensure we don't take excessive steps so to keep the costs manageable? So, first of all, I think it's important to communicate with your doctor who's ordering the tests for you so that you're very clear as to why tests are being done. And also, before they're done, perhaps, we have a business office and insurance offices here that can help you understand the costs and what may or may not be covered for you. And then you can make decisions with your doctor about which test you want to do before you do them. Next question, do you accept donor eggs currently frozen in another clinic? Dr. Alexander, you know about that? I can tell you that we do, but they're accepted with a lot of consent because we don't know what happens with those eggs because we don't know how they were produced when they're done in other clinics. But we're happy to look at them. There are some clinics we work with more than others because we have history. Next is going to be, I'm a 41-year-old single lady. I've never been pregnant because I'm single. I want a healthy baby no matter what. My AMH is 2.2. I will fly to Los Angeles. Will I be able to enter the cycle in time? Dr. A, you want to take that?
Sure. Yes, some people can do a video or a phone consult because that's important to understand how your menstrual cycles have been and the timing. In addition, it'd be nice if within a year you've had your pap smear, mammogram, and some preliminary blood tests. But sometimes people can get here and we can expedite some of the preliminary tests. But it's possible. It would be important to have a conversation to see how things are going and do a detailed medical history first.
So next is, do you perform TESE surgery? My husband has borderline DNA fragmentation and low OSA, semen analysis normal. It's a very interesting question because there's a lot of discussion about whether that's necessary or helpful or not. The andrologists, those are urologists who specialize in this sort of thing, have their own opinions about this. And since they are the ones performing the TESE surgery, we like consultation with one or more of them prior to doing so, because it is not that invasive. However, it's something that warrants discussion, I think, with the person performing the procedure. And that will answer the question, is it necessary? So let's see. Dr. A, do you see the next question? Is there a significant difference between freezing eggs at 37 versus 38? Currently having regular periods, but a history of endometriosis.
It depends on the follicle count as well as the day 3 FSH. But on the graph, when we look at the bar graph of age 35 to 37 versus 38, 39, there's a slight increase in chromosomal abnormalities in the eggs. But I tend to think that nature is nice and most of the time it'll be a similar outcome. And you have to do it at the time that works for you and with the protocol that will get the best outcome. So that's the way I approach it.
So there's another on success rates of surrogacy from egg thaw to created embryo and a healthy pregnancy. So the answer to that is going to be defined by what does your egg thaw give you? Because surrogacy should give you a relatively high implantation rate because by definition, surrogate is supposed to be a good place for a pregnancy to grow if they have in fact been evaluated properly, which is important to do to select a surrogate. So the rate limiting factor is not the surrogate, but rather the embryos that are created for this pregnancy. Dr. A, you want to talk about mini IVF?
Yes. So every month you ovulate one egg, but what's kind of neat with mini IVF is you don't take a tremendous amount of medication. So we don't give as much medication because no matter how much medication some patients take, they'll tend to make a few follicles grow. And so with a lower dose, we could tend to get the follicles to recruit without using a tremendous amount of the medication. Some places call mini IVF where in the embryology lab, they're not doing all the steps as detailed as we would. But so in my version or our version of mini IVF, it's just the protocol or the dose of the medications. But in general, we use ICSI, which is where we place the sperm into the egg and then discuss the pros and cons of genetic testing. Yeah.
So do you think shipping frozen eggs across the country is risky? You know, eggs, frankly, do not preserve as accurately or as well as embryos. If you think about it, the embryos that we transport are usually in what's called a blastocyst form, which is over 100 cells. The egg is one cell, and it's a cell that contains probably more water than most other cells in the human body, and therefore is relatively fragile. And the answer to that question depends upon where the egg's coming from. The patient, the clinic, the status of it. So you have to understand that shipping unfertilized eggs is much more of an unknown than shipping fertilized eggs or embryos. Let's see, there's the next one. What can be done with a high FSH male and zero sperm count? Dr. A?
So with the high FSH, we think of stress because the pituitary gland is the master control gland in the brain. So acupuncture, stress reduction, sometimes with a negative feedback loop, we can suppress the FSH. What was the second part of the question?
What specialist can be referred to?
For, oh, I see.
For the high
Well,
FSH and zero sperm count.
yes, in men with a high FSH, we work closely with what's called a male health specialist. So it's a urologist, but some of them are very focused on trying to understand why the FSH is high. So that means the testicle isn't doing its job. So looking at genetic mutations as well as if the person is taking any medications that could be doing this. So usually we'll work with the urologist. Some urologists are not experts in fertility. And so it's important to work with a fertility urologist to better understand why that's happening.
So the next lady asked about Tessie, and the question that she has is, her husband's urologist said it could help. Her question is, could a Zymot, which is a way of separating sperm, using ejaculated sperm be just as effective? And it depends upon the individual. It could be, if the parameters, including the sperm chromatid assay testing, are relatively normal, then you would think that it should be. So there's a question about, can there be a problem with the pituitary, and how can a physical issue be found? Dr. A?
Sure. We can do an MRI with and without contrast to the pituitary. The contrast they use now is gadolinium that doesn't hurt or, have a dramatic impact. They use a very low dose. And then they can look carefully at the pituitary gland to better understand what's going on.
Right. So what kind of PCOS treatments does your office offer? And I would say probably most all of them, ranging from medical therapy to assisted reproductive technologies to surgical therapy. Long ago and far away, there were surgical therapies that could be done by laparoscopy, which is rarely done because its effectiveness depends upon normal fertilization, which can sometimes be compromised with PCOS. That stands for polycystic ovarian syndrome. So the kind of procedures done in that regard are usually now called ovarian drilling, where you can make little holes with an electric cautery in the ovaries. And interestingly enough, in young, healthy patients without any other issues, that can be an effective way to start normal fertilization. Let's see, Tessie sperm better than fresh. Dr. A?
Fresh Tessie is better, but sometimes due to coordination, it can be challenging, or occasionally the urologist will tell us that they're concerned that they won't find any sperm on a Tessie. And so they'll do a determination on a day that it's not the egg retrieval day, so they can prepare for what they may expect. And if they find some, they'll freeze it. But there is a slightly better chance with fresh Tessie, but we have used frozen Tessie many times and had healthy pregnancies with that as well.
So are there one or two sperm banks that you would suggest? And, it depends upon where you are. There are usually good sperm banks in most large cities. So if you let us know where you'd like to go, we can try to help you. I think we're just about out of time, and we're very happy to answer any additional questions that any of you might have, either in person or remotely. So we want to thank you for your attention. Have a great evening, and we'll hopefully hear from you if you need anything. Take care.
Thank you, everybody. Best wishes.
Bye.